Morning. Thanks so much for having us. This is such a treat. Our objectives today are to review pharmacokinetic changes in pregnancy that may affect drug distribution and dosing, to discuss commonly used medications in pregnancy in women with heart disease, and to highlight controversies in medication use and models of shared decision-making in pregnancy. So by way of background, really any woman of reproductive age should be counseled regarding contraception, medication exposure, and family planning. And despite the availability of high sensitivity assays, many women don't discover they're pregnant until well into the period of organogenesis. So you may ask, what is the period of organogenesis? I know that's not something that a lot of my cardiology colleagues think about, but here you can see, and I'll ask Anne-Marie to point, that the period of what we call the period of the embryo is really from 3 to 8 weeks. And that's when probably the bulk of the embryo formation is. So the heart is really almost entirely formed by the end of 8 weeks. The brain and spinal cord are entirely closed by 10 weeks. So you can see that in this very early period, and again, many women may not know they're pregnant by 8 weeks. And certainly during COVID, we are not seeing women until much later. They may have already had exposures that we can't even quantify. The period of the fetus, which is really from 12 weeks on, extends until 40 weeks, which is the due date. 12 weeks marks the end of the first trimester. And you can see there that there's more functional development that occurs after 12 weeks, but really the bulk of organ formation is from 3 to 8 weeks. And next slide. And this obviously is important when you consider the statistic that 94% of women use at least one medication during pregnancy, and up to 63% used at least one medication during the first trimester. So you can see that this issue actually, I do maternal fetal medicine. I meet most women that I care for after the period of organogenesis. So really, you think you don't do pregnancy, but you may be doing more than you know with your patient population. And I would certainly say you have the privilege of taking care of women across their lifespan. And so these issues of counseling regarding contraception and talking to them about family planning and preparing for pregnancy really may come up for you as much as it comes up for me.
So our team is very interested in this topic, and we wanted to share with you just a little bit of our data. We started a protocol just over 10 years ago called the STORK Initiative, where we consented women and followed them throughout their pregnancy, doing standardized testing and collecting data at various time points during pregnancy and in the postpartum period. And we just wanted to share with you the first 571 pregnancies, some data on cardiac medications. This table will show you the first column is going to be the class of medications. The second column will be the number of women that were on those medications prior to pregnancy with the percentage of the overall cohort, and then those during pregnancy that were on medications. Now, I should mention that about 65% of these women have congenital heart disease. The others have various forms of structural heart disease or other cardiac diagnoses. But if you just look here, firstly, not many patients were on ACE inhibitors or angiotensin receptor blockers, and this may speak to our prenatal counseling. This is data taken at their visit just prior to pregnancy. However, other classes of medications are much more commonly used. For example, 25% of our women were on a beta blocker prior to pregnancy, and that number actually increased during pregnancy due to therapies for hypertension or arrhythmias. Another class of medications that was used frequently was aspirin or other antiplatelet therapies, with 15% of women on it at baseline. That increased to 24% during pregnancy. And we're going to talk more about some indications for aspirin as we go through this presentation, as well as some of the other forms of anticoagulants.
And one thing, actually, if you go back to that slide, Anne-Marie, that I was just noticing now that I'm looking at it again, is that I want you to look at is that actually, aside from the ACE inhibitors and the ARBs, most of these women stayed on their medication. And so that's another problem that we sometimes see is when women do discover they're pregnant, they stop everything. And so some medications increase, some decreased a little, but there is a pathway here for safe medication of all, safe use of all these medications in pregnancy. Okay, yeah. So just a little bit about the pregnancy pharmacokinetics. Many changes during pregnancy. Starts, as most things do, with the heart. They have increased cardiac output, leading to increased renal blood flow, increased GFR, which, as you can imagine, increases the clearance of many drugs. They have increased renal tubular transporter activities. The blood flow to the liver is increased, which increases first pass clearance. And there's active induction of the cytochrome P450 enzymes, which of course increase conjugation activity and metabolic clearance. Next slide. With respect to the heart and the lungs, as I mentioned, there is an increase in plasma volume as much as 60% by the third trimester. They have increased cardiac output, stroke volume, and in the third trimester, in order to augment their cardiac output even further, we see an increase in heart rate. The albumin falls, so whenever you run a panel on a pregnant woman, you see that low albumin, that's a normal finding in pregnancy. Coagulation factors and fibrinogen increase, leading to the pro-coagulant state of pregnancy. They have supine aortocaval compression by the uterus, and owing to chemoreceptors mediated through progesterone, endogenous progesterone, they have increased tidal volume and increased minute ventilation. So pregnant women have that increased drive to breathe. So you'll see them and they'll go, and that's not because they're short of breath, typically because of their cardiopulmonary problem. It's because they have this very powerful drive to breathe. Also GI changes, many of you are aware, we talked a little bit about the increased activity of the cytochrome P450, but nausea and vomiting of pregnancy. It's not just in the first trimester. Some women have nausea, vomiting up till 20 weeks. 5% will have it through delivery. And so all of these things can complicate medication administration. They have delayed gastric emptying, prolonged small bowel transit time, and of course, significant reflux.
So we thought one of the ways that we could discuss this topic was to share with you some of our patients and highlight some of the issues that came up in thinking about their medication use during pregnancy. So I'd like to present the first case. This is a 31-year-old G1P0 white, privately insured woman with a complex form of heart disease known as double inlet left ventricle. She had undergone a lateral tunnel Fontan and had come back and had covered stents placed in that Fontan without residual gradient. On her last evaluation, she had had normal left ventricular function, only mild AV valve regurgitation and aortic regurgitation, and a somewhat dilated ascending aorta at 4 centimeters. Yet she was asymptomatic, she played soccer weekly, she felt well, and when she became pregnant, the first half of pregnancy was very much uneventful from a maternal standpoint, although it was noted that the fetus was not growing particularly well. Things dramatically changed at 28 weeks gestation, where she presented with this very fast narrow complex tachycardia. She presented to an outside hospital, received 2 doses of metoprolol intravenously without much of an effect. She was then transferred to our center, where she got an additional medication, diltiazem, through the IV, and that resulted in significant hypotension. It was decided that she should undergo urgent DC cardioversion, and that did restore normal sinus rhythm. However, there was fetal distress, and the fetal heart rate went into the 60s, requiring emergent cesarean section for a small neonate, 1.3 kilograms. So we thought this case was important to discuss because it highlights some of the issues we see with medications that we're using for arrhythmias. Beta blockers, one of the largest classes that we use, and there is some published data about this. Here's one larger study. It was a Danish registry of over 900,000 births over a 13-year period. And in this time, Dr. Peterson and colleagues determined that 2,459 pregnancies were exposed to beta blockers. Now, what that means is that they found that these women had filled a prescription within 6 months of pregnancy up to 20 weeks gestation. They looked at various beta blockers, and they found that across the board, there was an increased risk of small for gestational age, defined as less than the 10th percentile, preterm birth, defined as less than 37 weeks gestation, and perinatal mortality, that is up to the first 28 days of life or stillbirth. What was interesting to us is when you look at this data, they compared labetalol, which was by far the largest used beta blocker in this group, to all the other beta blockers combined. And there really was no difference in risk for these women, depending on which beta blocker they chose.
So just to sort of drill down on the beta blockers a little more, because I think these are, as you saw from our data, and I'm sure in your own experience, overwhelmingly some of the most common cardiac medications that we use in pregnancy. I think that people spend a lot of time trying to figure out, is this one better? Is that one better? And when I am asked, I always start with, what do you think the best medication for this patient's condition is? And typically these are the three medications we're talking about. So atenolol, more early on, had a little bit of a bad rap because it showed sort of in an earlier database a stronger signal for growth restriction, and it fell out of favor as use. But as Emery points out, like the overall beta blockers as a class are all associated with some growth restriction. So atenolol, maybe metoprolol, we have good data that there's no congenital anomalies associated with it, but also we do see some growth restriction with metoprolol, and many of these things are dose dependent. So the higher doses women are on, the stronger the effect is. But of course, the higher doses women are on, it's for a reason, right? They may have worse underlying disease, and they may have other factors that predispose them to fetal growth restriction. And then labetalol, which we use all the time in pregnancy. It's our #1 agent for hypertension. Really does, for sure, we've not seen any increased risk of congenital anomalies, and certainly it has not shown itself to be any worse for growth restriction. And this is, as you'll hear later, really our go-to agent. So many of you, I put this slide in, I feel that many of you are probably aware that in 2015, the FDA moved from their original ABCDX categorization to the new pregnancy and lactation labeling rule. This is a far more descriptive way of looking at medicines and assembling a body of literature regarding them. And what they've done is they've combined sort of pregnancy and labor and delivery all into 8.1, which is all pregnancy. And then 8.2 is lactation. And then they have what I think is probably the most useful category, which is females and males of reproductive potential. So this is for everyone you're seeing who's not pregnant or lactating. And I think really this applies to the majority of the population that you will all see. It's an excellent resource for information. And you'll see later, we'll have some other helpful resources as well.
So thinking about this first patient, we thought we should discuss just a little bit more about antiarrhythmic drugs that could be used in pregnancy. As we go through this discussion, we will show you figures such as this one. This is taken from a review that we worked on with Dr. Dan Halperin, one of our colleagues, looking at cardiovascular medications during pregnancy. So let me orient you to this figure. We have the group of drugs here. The first column, the bubbles are going to indicate the safety in pregnancy. Now the colors are green, would be considered safe. Yellow, which you will see a lot, is just that there's limited data, so we really have to use these with caution. And red is contraindicated. Blue is conflicting data, or those that's largely unknown. So that first column will be safety. The second column is that FDA category that's no longer used, but here for historic benefit. The third column, very importantly, relates to safety during lactation. And we know that after women deliver, we're always considering which medications will be safest both for mother and baby. And then the last column, when indicated, are those therapies that could be used for fetal therapy as well, such as here, digoxin, sotalol, digoxin, flecainide, and sotalol.
So that's for like fetal arrhythmias, just for people who aren't familiar. And those medications are typically given at much, much higher doses than you would typically give to treat the mother when you give it for fetal therapy.
Thanks. And I think that the bottom line here is that many of the antiarrhythmics, really with the exception of amiodarone, can be safely used for the treatment of arrhythmias during pregnancy across all gestational ages. When we get into some of the higher class antiarrhythmics, we're working with our electrophysiology colleagues to determine safety and best practices as well. So in this first case for this woman, we really used metoprolol and then diltiazem in the acute setting when needed, and we discussed the fetal distress that occurred, resulting in an urgent delivery. Now let's go on and think about a second patient. This is a 26-year-old G1 P0 white publicly insured woman who has Epstein anomaly, and she'd undergone a cone procedure back in 2008. Unfortunately, at that time, it was complicated by a right coronary artery injury and left her with severe right ventricular dysfunction. This cine image is one of her images from a cardiac MRI that was performed, looking here at the right side of the heart, so SVC coming into the right atrium. Here's this dysfunctional right ventricle, and you can see the repaired now tricuspid valve, which does form what resembles a cone. Sadly, 1 year after this MRI was taken, she suffered a ventricular fibrillation arrest and subsequently underwent ICD placement. So when she presented to our program, she was on a number of therapies. We've highlighted them here. Sildenafil was started shortly after her arrest to promote forward cardiac flow. She was on amiodarone, as well as carvedilol and furosemide. Her dose of furosemide was 40 milligrams twice a day. And she presented with an unplanned yet desired pregnancy. She had a difficult course with recurrent admissions. In fact, at 19 weeks, she came in with nausea and vomiting. Her respiratory status was stable. She did not require oxygen, but she tested positive for COVID. Perhaps I could just ask Dr. Akami to comment. You know, this woman presented to us just under a year ago, but now for women that present during pregnancy with COVID, are there therapies that we're using?
Absolutely. So many of you may be aware that in the initial trials, pregnant women were entirely excluded, not only from the medications, but from vaccines, and that created appropriately an enormous uproar. And now pregnant women are being enrolled at rates in these trials. Back when she was admitted, I believe we were still using remdesivir. We had to use it under sort of special exception. Now, women who come in who meet criteria for moderate to severe disease are all candidates for antibody therapy. Of course, now we have Omicron, and we're targeting those therapies, and the availability of these therapies are limited. But if pregnant women meet criteria, they're absolutely candidates for it.
Thanks. Thankfully, she didn't need to stay hospitalized too long and was able to go home. But unfortunately, she presented several weeks later. Now, this was at 23 weeks of gestation, and she was in significant heart failure. This is a quote I took directly from her chart. She reported worsening dyspnea on exertion over the past week. She was exhausted, unable to sleep at night due to the inability to catch her breath. She was using 3 pillows with persistent symptoms. She could walk from room to room with only mild dyspnea, but then she needed to stop. She could barely reach up 1 flight of stairs, needed to sit down for greater than 5 minutes just to catch her breath. And on exam, she was in significant volume overload. Her furosemide dose was actually titrated up to 120 milligrams orally twice a day at that time.
So as you can see, she was struggling during pregnancy, and we continued to up titrate her medication. This is a good example of shared decision making. You saw that in some of our earlier slides. Maybe furosemide is a medication that we might take off somebody during pregnancy. Here's a woman who needs it, and we're increasing it without worrying about the side effects, because having her be healthy is what's going to keep her baby healthy. We admitted her ultimately at 36 weeks, 5 days. So 37 weeks is term, just to remind you, with a plan for delivery after medical optimization. We did have intricate labor and delivery planning with plan for backup right ventricular mechanical support if needed. Ultimately, she underwent an uncomplicated induction of labor and had a spontaneous vaginal delivery of a healthy male fetus that weighed 3 kilos. So I think this is a very good case to talk about some of the complexity of shared decision making. So this patient came in on amiodarone, which is typically for us, if we see someone preconceptually, one of those no-no medications. We really only use it after other antiarrhythmics have failed. It's a highly lipophilic drug. It accumulates in muscle and adipose and the fetal compartment. It probably has about a 20% incidence of fetal goiter. And so, and fetal goiter itself can subsequently lead to neurodevelopmental abnormalities. So in her case, and you can see this ultrasound, you have a sagittal view of a fetus. And the arrows, the black is fluid, as I know you are all aware. And you can see where the arrows are pointing, that sort of bulbous structure underneath the chin is the actual fetal goiter. And that's not a normal finding. Normally a fetus exists in a more flexed position, and sort of the pathognomonic finding is a baby that can't flex its head on ultrasound. You always look to the neck to see if there is a neck mass. And in this case, you can see a fetal goiter. Now in her case, we went back and forth to consider, well, should we stop it? And it was felt really strongly that this was an appropriate life-saving medication for this woman, and we elected to continue it. We did involve, as part of our multidisciplinary decision-making team, a pediatric endocrine consultation to make a plan for the baby after the baby was born. Next slide. So in contrast to amiodarone, I think that an ACE inhibitor and the ARBs really are much more entirely contraindicated. There is probably, in the last 25 years, I can think of, I can count on one hand the time we've even talked about using an ACE inhibitor for a pregnant woman. And this is another ultrasound. So you remember the sagittal image you saw before. So this is actually a similar sagittal image, but this fetus has no amniotic fluid. And so this is the finding we see most commonly with ACE inhibitors, which is they affect the fetal kidney, leading to decreased amniotic fluid production. So amniotic fluid is fetal urine. Fetuses can develop renal failure. They stop making urine, and then a knock-on effect of that is abnormalities in the skeletal development. They can't move their arms and legs. They can't develop their muscles. And most lethal is that they cannot develop their lungs. So they no longer have normal fetal breathing motion. They no longer breathe fluid into their lungs and expand them. The lungs become hypoplastic, and at birth can't sustain extrauterine life. So I would say this is something, in contrast to the amnio, where we would consider using it. An ACE inhibitor or an ARB is something we would really not consider using.
So this case really highlights some of the intricacies in treating women with heart failure during pregnancy. And this is a helpful algorithm from the European Society of Cardiology that was published a few years ago, looking at women with peripartum cardiomyopathy. So just to highlight, if you start on this left side of the slide, for women that present with severe cardiopulmonary distress, decisions get made very quickly about optimizing preload, oxygenation, adding support in the form of inotropes or vasopressors, and really urgent delivery considerations, as well as occasionally and rarely thinking about mechanical circulatory support. More often, as was the case in this woman, she had a cardiomyopathy but was not in significant distress for the most part. So we really focus our antepartum therapies on those heart failure therapies that we consider to be the more safe ones in pregnancy. And they're highlighted here: hydralazine, the nitrates, beta blockers, diuretics. Following delivery, then, we're going to go back to standard medications, and here's where we reinitiate the ACE inhibitor or the ARB, as well as spironolactone other therapies, and more recently now, even sacubitril valsartan sometimes is considered. For peripartum cardiomyopathy specifically, it's important to discuss the therapy bromocriptine. There is evolving evidence that this is helpful, although bromocriptine will suppress lactation. So again, this is an example of shared decision-making. So as we put together the second woman's case, we used several different classifications of medications, including carvedilol, which was considered safe, as well as furosemide, but ended up at very high doses. Additionally, interestingly, she was on a pulmonary vascular agent that was started at the time of her cardiac arrest to promote forward flow. We chose to continue that at well. There's really limited data in this area on the PDE5 inhibitors in pregnancy. However, these are the types of decisions now that we're thinking about. Okay, let's move on and do a third case. This is a 44-year-old G3P2 Black Hispanic woman who was publicly insured, and she had rheumatic heart disease. She had a significant cardiac medical history. She presented at age 33 in atrial fibrillation, was found to have a left atrial appendage thrombus and a stroke. At that time, she was diagnosed with severe mitral stenosis, and she underwent a 29mm St. Jude mitral valve replacement. Then at age 40, she was found to have heart failure with a left ventricular ejection fraction depressed to 35%. 1 year prior to her pregnancy, she experienced a second stroke. Sadly, this was when her warfarin was being held due to heavy menses. So we first met her at 10 weeks when she was in permanent atrial fibrillation at 75 beats per minute. And we've listed her medications there. In the setting of a mechanical valve, she was on both low-dose aspirin as well as warfarin. Her dose of warfarin was 10 milligrams 2 days a week, 7.5 milligrams the other days. She was also on metoprolol, iron, and magnesium. When we met her, she had been seen, and her 3 medications had been stopped due to the fact that she was pregnant: sacubitril valsartan, spironolactone, and atorvastatin.
So you noticed that she was on warfarin appropriately, and warfarin's another good example of joint decision making. I think we'll talk a little more about it later as well, but typically when women present on warfarin, we look at their dose. In women that are less than 5 milligrams a day, their risks do seem to be lower. At greater than 5 milligrams, they have an increased risk of this classic warfarin embryopathy, which includes the findings of nasal bone hypoplasia, stippled epiphyses, growth restriction, microcephaly. And those are, if you'll remember our graphic from the beginning, all due to first trimester exposure, less than 8 weeks. Later exposure can result in fetal bleeding complications. So this is a transverse image of the fetal brain, and you can see in the posterior fossa there, that bright white image is actually hemorrhage into the posterior fossa. I think that spontaneous intracranial hemorrhage is a rare outcome, but one that we've definitely seen reported in the literature, so we try to be careful. You may remember that this patient's dose of Coumadin was actually 10 milligrams on 2 days and 7.5 on 5 days, and so she really was above the amount that we would consider keeping them on in the first trimester. However, her risk was so great, her stroke history was so impressive that really we did not feel that it was safe to switch her over. And so this is another example of having conversations with the patient about the risks and benefits. And what I often find is that women themselves are very, very motivated to take care of themselves when they have been through so much. So she was very much on board with continuing her warfarin. Next page. Her prenatal course was generally okay, although she did begin to miss visits due to transportation issues. She had both food and housing insecurity, and despite sort of multiple attempts to connect her through a variety of social services, she had sporadic prenatal care. and then presented, unfortunately, at 32 weeks, 5 days, having had 2 days of decreased fetal movement, and was found to have an intrauterine fetal demise. At the time, her INR was 2.0, obviously less than her target range, but not nothing. So she had been taking some medication, but not adequate. I don't think that her stillbirth was related to her anticoagulation in any way, but of course then it became a complex conversation for her delivery. So typically when women have a stillbirth, of course, we'd like to start their induction right away. In her case, we did delay it while her INR normalized. And then she underwent an uncomplicated induction of labor, restarted enoxaparin 6 hours postpartum as a bridge to warfarin. Her fetopsy findings were consistent with uteroplacental insufficiency. So really the stillbirth was likely a result of placental problems. She had other risk factors for stillbirth, but overall in this case, we felt that sort of more regular prenatal care may have helped matters.
So women with mechanical heart valves are some of the most challenging cases that we manage during pregnancy. And you can see there are several choices for anticoagulants. And as Dr. Economy mentioned, we chose to continue warfarin at a higher dose. We can look to the American Heart Association, American College of Cardiology guidelines for patients with valvular heart disease. Looking here at this algorithm, recognizing that class 1 recommendations are going to be highlighted in green, the class 2A are in yellow, and the class 2B are in orange. No matter which anticoagulant you use, it is so important to do frequent, meticulous monitoring. However, if you think about it, the newest recommendation says that warfarin doses of 5 milligrams or less, if women are on them, could be continued during the first trimester. But really here, you have 3 different approaches you could do. The 2A recommendation would be to continue warfarin at that lower dose, or you could consider using dose-adjusted low molecular weight heparin with frequent monitoring of anti-10A levels, or dose-adjusted continuous infusion of unfractionated heparin. Any of those choices could be considered. Our patient presented with this baseline warfarin dose of greater than 5 milligrams a day. In this case, oftentimes in the first trimester, people may choose to switch to one of the heparin therapies. Once you're through that first trimester and that period of organogenesis, we then in the second and third trimester strongly favor warfarin for these women with the addition of a baby aspirin right up until the time before a planned vaginal delivery. We worry about women delivering when they're fully anticoagulated on warfarin due to the risk of maternal and fetal hemorrhage. So we're then going to discontinue the warfarin and use the heparin in that period of time during delivery. But these are complicated choices that we have to make. Okay, let's discuss one more case. This is a 43-year-old G8 P0654 Black publicly insured woman with diabetes, hypertension, hyperlipidemia, and obesity. So multiple cardiac risk factors here. And she had presented with a non-ST segment elevation MI in the past year. In fact, this still frame angiogram is her coronary angiogram at that time, where you can see she has a complex lesion at the proximal portion of her LAD. They did a FFR wire and found this not to be flow limiting, so they did not intervene on this. We met this woman at 18 weeks gestation when she presented with persistent chest pain. She was on a number of medications. I should mention her statin had been stopped at the time she learned she was pregnant, but at 18 weeks, she was on a baby aspirin, Betalol, amlodipine, isosorbide, as well as insulin. So thinking about her obstetric history, Dr. Economy, maybe you could go through this with us.
Sure. I know that the G's and P's, Dr. Valente knows these cold, I'll have you know, don't let her fool you. But this patient has a very, very complex obstetric history. And so when you look at it, so G's are the number of pregnancies, and then P's are sort of divided up between first trimester and second trimester miscarriages, preterm births, term births, and live births. So her history, when you look at it, is notable for all of her babies that she went on to deliver. were complicated by either hypertension or severe preeclampsia. So she had a 38-week delivery with severe preeclampsia. She had a 36-week induction of labor with preeclampsia. She had an IVF triplet pregnancy, which unfortunately resulted in rupture of the membranes of the first two twins in the second trimester. And then at 24 weeks, she presented with infection, which is an unfortunate yet common sequelae of early rupture of the membranes. That pregnancy was also complicated by hypertension. She had to have an emergency cesarean delivery, and only one of her children survived. She had an ICU admission in that pregnancy with both hypertension and infection. And then her most recent prior pregnancy, she made it to 38.5 weeks, at which point she underwent a repeat cesarean delivery in the setting of hypertension and diabetes. So when we met her, some of the things that we thought about in reviewing her medication, she has this very significant history of preeclampsia. And one of the things that's emerged probably over the last, I would say, 7 to 8 years is that aspirin, low-dose aspirin, may in fact have a very strong protective effect for women with a history of preeclampsia to prevent hypertensive disease and preeclampsia in a future pregnancy. So preeclampsia is something we have been studying in obstetrics for 50, 60 years. And really, this is the first time I think we have moved the needle on preeclampsia prevention. So this is a recommendation from the US Preventative Services Task Force, which basically suggests that low-dose aspirin use, 81 milligrams a day, starting at 12 weeks gestation and continuing through delivery, is appropriate in women who are at high risk for preeclampsia. Now you may ask, who is at high risk for preeclampsia? And I would say anybody with hypertensive disease. And these are recommendations from both the National Institute for Health and Clinical Excellence and the World Health Organization that sort of echo this recommendation from the US Preventative Services Task Force. And essentially, any woman with hypertension prior to pregnancy, any woman with a history of hypertensive disease in pregnancy or preeclampsia, chronic kidney disease, autoimmune disease, type 1 or type 2 diabetes, those are absolute indications. We also use multiple gestations as an absolute indication, but you can also qualify if you have 2 or more minor risks, which would be it's your first pregnancy, you have an age over 40, a BMI greater than 35. So you can see that this really encompasses an enormous amount of our pregnant population. And I would say perhaps that low-dose aspirin is the new prenatal vitamin, basically the way we have been using it. I would point out that most of the data comes from European literature, and there the dose of low dose is 150 milligrams, which actually we can't get down here in the lower 48. But so what I often have my patients do is either take 2 81 milligrams or take a second one every other day. And other things that we've tried, I bring this up just because I think that you'll notice, you may remember that this patient had been taken off her statin. And so here's a woman with coronary artery disease, high risk, prior non-STEMI. So she has very high risk and would normally be someone you would like to leave on their statins. I think that statins have kind of bad press, but we in the OB world have been looking at pravastatin for a long time for preeclampsia prevention. And so this is a recent multi-center double-blind trial that was published in Circulation, which actually looked at pravastatin started kind of late in the 3rd trimester at 35 weeks. They randomized women to pravastatin or placebo, and it didn't actually reduce the incidence of preeclampsia in a statistically significant way. However, we have lots of safety data about pravastatin use in early pregnancy. And so in my practice, I have been leaving women on some of their statins, and this data is being updated all the time. So it's something to consider when you see a patient on a statin, to check the registries for what the most recent safety data is. So she progressed in her pregnancy. She had multiple episodes of chest pains for which she would call us and then not do anything, which gave us chest pain, of course. She would call us and say, well, I took 5 or 6 nitroglycerin and I think I feel better. Ultimately, she had multiple admissions for exacerbation of her hypertension. We up-titrated her labetalol, amlodipine. We started nifedipine. We talked about starting a fourth agent. And then at 34 weeks, we admitted her for delivery. So on increased doses of labetalol and oral furosemide. So lots of data on treatment of hypertensive disease in pregnancy. One of the things that I think Dr. Valente may sometimes find surprising is the way that we in maternal fetal medicine approach new onset mild to moderate hypertension. Now, this patient that we're talking about definitely is in a different category with all her underlying disease and her severe range blood pressures. But we have in our world a lot of recommendations that women with mild to moderate hypertension should not be treated with antihypertensive therapy. Women who have persistent chronic hypertension, and that is systolic blood pressure greater than 160, diastolic blood pressure greater than 105, should be treated with antihypertensive therapy. So those are much higher doses than higher range blood pressures than I think you are all used to sitting on. And this comes largely from this New England Journal of Medicine article, the CHIPS trial, which was a multi-center trial of 987 women who were randomized to what they called either less tight or tight control of their hypertension in pregnancy. And essentially what they showed was that, you know, really in the overall stratifications, there really were no differences in outcomes in serious morbidity. Women who had less tight blood pressure control did have a higher chance of progressing or developing severe hypertension, which they defined as blood pressure greater than 160 over 110. And you can imagine why that's true. If you're treating somebody, they're not going to progress. But if you go to the next slide, you'll see that their risk for serious morbidity was actually no different between the two groups. And the risk for progression to preeclampsia was no different. And so that was the primary endpoint, was could you prevent preeclampsia by controlling blood pressure? Now, one point to make here, so to summarize this trial basically, and the obstetric guidelines that have emerged from it, is that, you know, treating blood pressures, you know, you should treat blood pressures that are greater than 160 over 105 to 110. You could treat the ones between 150 and 160 and between 100 and 105. You may decrease progression to severe hypertension, but there's no evidence that overall outcomes will be improved. And importantly, there doesn't seem to be increased fetal harm. So there was a lot of concern initially about lowering blood pressures too low, and causing fetal effects. So you may remember our first case way back when, which essentially that patient came in with her arrhythmia, got treated with a beta blocker, got treated with diltiazem, dropped her pressure, and subsequently had a fetal bradycardia. That baby was growth restricted, likely was used to seeing much higher blood pressures, and really couldn't tolerate the fall in blood pressure. So we are very, very careful about over-treating women with hypertension, particularly in women who have small babies or any concern for uteroplacental insufficiency. And here's just a summary table of some of the blood pressure goals that we use. And you can see that for gestational hypertension, we are really not very aggressive until they reach severe range. Same for preeclampsia. I think for women with the two categories that are exceptions are women with chronic hypertension on medication and women with chronic hypertension with any end organ dysfunction. And the patient that we're talking about would surely qualify for that. And in those women, we are much more aggressive in treating their pressures, but always with an eye to their fetal well-being. Next slide. And here, as I mentioned previously, these are the medications that we standardly use. This is essentially what we have in our armamentarium. Labetalol, that dose is usually 200 to 2,400 milligrams in 2 to 3 divided doses a day. Nifedipine in 30 to 120 milligrams a day of extended release. I will make the point that nifedipine is one of those ones that we do see a lot of increased clearance for, and in pregnancy, we often find ourselves giving extended release nifedipine BID. And then methyl-dopa is kind of an oldie but a goodie. We don't use it very much, but I have to say, whenever I talk about this topic, there is always somebody from the audience who asks about methyl-dopa. So I know you're out there, and the answer is yes, you can use methyl-dopa. There's tons and tons of safety data. I just don't see it working that well. But I don't think you can really hurt somebody with methyl-dopa. So very, very safe agents, probably the one that's been around the longest.
So in this woman's case, she came in the day of delivery with, again, very high blood pressure, over 160 over 90, and we had to control that with IV medications, Betalol and Hydralazine. She ended up undergoing an uncomplicated repeat cesarean delivery under epidural anesthesia, and postpartum continued to struggle with severe range blood pressures, responding to intravenous Betalol and Hydralazine. She was able to be discharged home postoperative day 4 with an increase in her baseline Betalol.
And so again, in contrast to those oral medication table, which we just reviewed, this is our IV, our acute hypertensive crisis table. And into this table, we introduced hydralazine, another medication that has a lot of safety data in pregnancy. So we would probably use labetalol and hydralazine interchangeably for first line for management of acute hypertensive crisis. Hydralazine, you'd start at 5 or 10 IV push every 20 minutes. Typically what we would do is give 2 doses of one medication, and if we're not seeing an effect, we will switch to the other medication. Nifedipine is a fairly profound, causes fairly profound lowering of the blood pressure. That being said, we tend not to use it in patients who already have established IV access. Nifedipine is a very good choice. We see that for women who come sort of rolling in acutely hypertensive and need urgent treatment of their blood pressure. We see this a lot in obstetrics. We see a lot of people roll in acutely needing all kinds of treatment. So nifedipine we use typically in that setting while we establish IV access. The other agents are really more second line agents. We always talk about sodium nitroprusside, and someone will mention, is there concern for its metabolism to cyanide? Yes, but probably not at doses that any person would reasonably use. If you're using doses that high, you should really be trying a different agent. But yes, that is metabolized to cyanide. Yes, it could conceivably be transferred to the fetal compartment, and nitroglycerin very safe.
So just to sum up, there are various agents that we can use to treat hypertension in pregnancy. We do look to those ACOG recommendations and find those tables helpful. Now, in the last couple of minutes, and we definitely wanted to save time for questions, but Dr. Economy wanted to share some other fun facts of common drugs that we use on labor and delivery with cardiac effects.
It's not totally clear to me that we all have the same idea of fun, but this is fun for me. So we will go through this very quickly because we do want to make sure that you have time for questions. So if you are called to labor and delivery, you will hear about all of these medications. Oxytocin is a medication we typically use to induce labor, as well as to help the uterus contract postpartum. Important to remember, it may cause PVCs. IV boluses routinely cause hypotension, so we keep our eye on that. Metrogen is probably the worst actor from a cardiac perspective that we use. It is a very potent uterine contractile medication, so we use it in the setting of postpartum hemorrhage, and we really like it. However, it definitely increases SVR, increases mean arterial pressures, can cause pulmonary edema, so we really avoid it in any patients with hypertension. Prostaglandin F2 alpha heme is a medication that we also use for hemorrhage to contract the uterus. We avoid this in women with asthma because it may cause bronchoconstriction. And misoprostol, which is prostaglandin, I think it's E1, we use mostly for induction of labor and has a lot of side effects like diarrhea, fever, headache. Typically doesn't have so many cardiovascular side effects, but it is a medication that we use a fair bit. Slide. Nifedipine, we've talked about several times. We also use, in addition to hypertension, we use nifedipine for tocolysis, which is the doctor word for stopping preterm labor, stopping contractions of the uterus. We use very, very high doses of nifedipine, 20, 30 milligrams over an hour, and then 20 milligrams Q6 hours for 48 hours. We use azithromycin typically for women who come in with preterm rupture of their membranes because we think it may prolong their gestation. It can also, unfortunately, prolong their QT, particularly when used in conjunction with other common medications like ondansetron. And we use a lot of indocin also for tocolysis or fibroid pain. However, we rarely use this after 32 weeks because of the risk of premature closure of the fetal ductus arteriosus. And I mentioned that we'd share some databases. The first one is an international database, embryotox.de. I would suggest, unless you are fluent in German, you click the Google Translate, and it translates very nice into English. I checked it the other day. The LACMed is specific for breastfeeding from the National Library of Medicine and NIH, with all the up-to-date information about breastfeeding resources. And then Reprotox is an excellent source. It does require a subscription, but they do both a basic science, a early pregnancy, a registry, and a lactation section. And so it's a really worthwhile database, which our hospital owns and many academic teaching hospitals own for their providers.
Well, thanks for sharing those fun facts.
I can tell everybody thought it was really fun. Just to summarize, there are many hemodynamic and metabolic changes which affect drug distribution and clearance in pregnancy. Many common cardiac medications can be administered safely. I think you've seen that over the course of this talk. And of course, medication used in pregnant women with cardiac disease required shared decision-making to balance risks to the mother and fetus.
So we really appreciate everyone joining, and we're happy to take questions. A big shout out to our team here in Boston that we have worked with and are thrilled to be supported by philanthropic support as well to answer some of these questions. Thanks very much.
Thank you, Anne-Marie and Kathy, for an excellent talk and the review of a difficult topic. So if anyone has any questions, please unmute your microphone. So write them in the chat. I can see Candice already put her camera on, so I'm sure that Candice must have a comment. So Candice?
Well, I just wanted, I can't even see myself, so I don't know if my head's cut off or not, but I just wanted to thank you too. That was such an excellent talk. I love the tag team thing, and really it's such a pleasure to hear you too. I just wanted to commend them on just like an absolute state-of-the-art talk. Thanks, guys.
Candice, you look great.
Okay.
Yeah, we can see you all, Candice. So
Okay.
the camera is perfect. So if while people think about questions, and nobody has anything on the chat as yet, I have a couple of questions. So it's quite through your presentation, the cases that you presented, it's quite obvious that many of the women just present late to us when they are already pregnant. As Kathy, I like the comment that you said, even if you don't do pregnancy, you don't realize that actually you do it, because it's a role of counseling these patients that I see every year or every 6 months. And my question is, when is the right timing to send someone for a preconception counseling? Because that's one of questions. When is the right time? Somebody comes to your clinic, maybe in their 20s. Yeah, well, I might want to become pregnant in the next 5 years, but I'm not having.
There's no wrong time. That's for sure. I think that we do maternal fetal medicine, but when we see a preconceptual consult, we can also talk a little bit about family planning. Many institutions have family planning things. I think any woman of reproductive age in your practice, it's not a terrible idea to kind of acknowledge that they could get pregnant, and are they using contraception? And if they say, I'm thinking about getting pregnant in 5 years, say, great, you know what? Let's have you meet this person now. And then this happens a lot with Dr. Valente and I. She may send me someone, and that person, will talk, and then I'll see them again 3 years later for an update. So it's a good idea though, because there's so many things that they're not thinking about. And then there are other risks that sometimes I find that might complicate their pregnancy risk, and they may change their reproductive decision making. They may decide, you know what, I'm actually going to get pregnant in 2 years, or now I'm going to wait more time. So I think actually, if you're already having that conversation, you're already ahead of the game. If someone mentions the word pregnancy in your office, that's a good time to send them for a consultation. Really, there's no, I think it's, and I can't tell you the number of consults I've done with young women and their parents there. That part, that's fine too, right? I think these are important issues, and nobody benefits when we try to kind of sweep them away or wait to talk about them. That is the patient that will show up pregnant, for sure, 100%.
Just following that, can you people please unmute their microphones? I noticed that you said that you see the patients also for preconception counseling, and my question is, who should do it? The cardiologist, the obstetrician, independently, or together? How do you do it in Boston?
Thanks, Rafa. We try to do things collaboratively. So we both share information. Sometimes we do it together for very high-risk women. We'll go, for women with mechanical valves, we might go in together and talk to them about risks and strategies through pregnancy. But we communicate a lot about each of these individuals, so we can highlight different things. But I think it's really not the responsibility of one clinician more than another. It takes a village.
Okay, there's some questions in the chat that I want to go through. I know it's already 9, but there are 3 questions that I would like to ask. One is for Dr. Brenda Young in Coruña, in Spain. That's good morning, very nice presentation. So I was disappointed to see the results regarding treating the gestational hypertension. So obstetricians used to start treatment with mild hypertension. Cardiologists maybe are more conservative. Is the same in your practice? Do you start early? Which limits do you think to start methyldopa? When would you consider starting methyldopa?
Well, maybe I'll start. I think that for us, so again, it depends on the patient that you're talking about, but let's say you have a healthy pregnant woman who begins to develop hypertension in her pregnancy. I will not start medication until they have blood pressures that are, their systolic is above 150 and their diastolic is above 100. And honestly, in some cases, it really depends on their gestational age. Many of these women may need to be delivered. So we didn't have time to present lots of data that, there isn't a lot of benefit to, especially once a woman reaches 37 weeks with doing anything but delivering her. There is not a real treatment except for delivery after 37 weeks. So in that time frame leading up to term, I won't, in an otherwise healthy woman, I wouldn't start medication in the 140s/90s, for instance. I think we have lots of data to suggest that we don't improve any of our short-term outcomes for the mother and baby by starting medication. I think that any woman with any underlying health concerns, renal disease, cardiac disease, right, which is most of my practice, of course, we're much more conservative, and I would start anything in the 140s/90s range. Did that answer the question?
Yes. Yeah. So Dr. Swam from Scotland said that was a great talk. Thank you. So do you have any specific metal valve anticoagulation care plan that you give to the patients pre-pregnancy?
So thanks. That's a great question too. I think that as far as resources, we don't, at least our practice doesn't hand out specific resources, but we guide patients through what's recommended through the ACC and AHA guidelines right now about the different therapeutic options, with strong understanding that some of those anticoagulants are going to more greatly protect the mother versus the fetus. And so starting with that, we then go from there. But it's important to, I think, develop more resources for women to be able to share in pre-pregnancy, specifically the ones that have mechanical heart valves, because it's so challenging to manage the anticoagulation.
I mean, and as you saw with this patient, I mean, guidelines are just guidelines. Like, we did a very individual plan for her where we kept her on a higher dose warfarin during her first trimester.
Mm-hmm. 2 more questions. Another one from Dr. Walker, again from Scotland. Say, if you see a patient in pre-pregnancy counseling who has been on amiodarone long term, but who can be tried off amiodarone, so how long would you ideally ask them to defer pregnancy to minimize the amiodarone-associated fetal complication?
I think if you switch them preconceptually at 3 months, you're going to be fine. So, and when you see them, right, start them, make sure they're taking a prenatal vitamin, right? Everybody should be on folic acid too for 3 months prior to conception. So if you're switching someone's meds, if you have the bandwidth, ask them about their folic acid too.
And I will just add, I think I tend to ask for a little longer time for the transition, specifically for amiodarone, but 3 months is great if we can get it. The thing that I learned with our second case about amiodarone is those fetal toxicity effects on the thyroid are not dose dependent, which is something I didn't realize. So it really is just being on the medication at all. So we do try very hard to get them off it well ahead of time.
Okay, so and the last question from Robin from Winnipeg. So when managing pregnant women with mechanical valves in pregnancy, how often do you check anti-10A or INR? Once a week, more often, less often? Does method matter?
You want to take that one, Dr. Valente, or you want me to?
Again, it all goes, these are all individualized decisions. We do have a protocol, especially early in pregnancy, if someone's using low molecular weight heparin, where we are checking levels quite frequently, at least weekly, and then making dose adjustments. And then as things come up and we consider different options, we really do try to transition most women to warfarin by the second trimester. So it's that first trimester where we're checking quite frequently.
And it's critical to add here that you absolutely have to check their trough. Okay, so I think that when so in pregnancy, at least for other things, thromboembolism, when we're checking levels of anti-factor 10As, low molecular weight heparin, we check a 4-hour peak. But in this patient population, you absolutely, we do both a trough 30 minutes before and a peak 4 hours after.
Okay, I think, yes, for the sake of the time, I think we could be discussing the topic forever, but we're going to stop here. I want to thank you both again for the fantastic talk. And I think that the interaction between both of you has been amazing. So you have actually got it together very, very well. So thank you for being with us today. And for the people that joined the session, thank you for joining us. And see you in next week in our international runs. And good morning, good afternoon, or good evening, wherever you are in the world. Thank you, Maria, and thank you, Catherine. Bye-bye.
Thank you. So lovely. Bye.